land on which the Fields Institute operates for thousands of years. It's been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, this meeting place is still the home to many Indigenous people from across Turtle Island, and we are grateful to have the opportunity to work on this land. And now I will give it over to Zhen Hong, who will introduce our colloquia speaker today.
Thank you. So I'm very pleased to present the speaker today, Seyed Moghadas, a colleague of mine at York University and a member of our own Mathematics for Public Health network. And Seyed is well known to all the participants, and he has been widely consulted here in Canada by the Ontario Science Table, by various different agencies from the federal government, and he's also widely consulted across the border, especially in the north, by U.S. government. I remember the White House report summarized some of the acknowledged that some of his work really played a significant role in forming some of the policy, and probably he served on both the Biden and Trump's administrations. I'm very happy that Seyed is here, give some updated study of the U.S. data. So Seyed.
Hey, thanks very much, John Hung, for the kind introduction. I'm going to share my screen. Okay, and this hide floating. Okay, and you can let me know if there's a problem in seeing my screen.
The screen is very good in the full screen.
Yes. Okay. All right. Thanks very much, John Hung, and everybody for organizing this colloquium and very kind introduction. What I want to present today is going to be a recent work that we did on return on investment of vaccination campaign, specifically for New York City. So I tried to actually be brief on the talk and maybe give a little bit more time to this discussion and any questions you might have. Okay, so let's just start with timelines of interventions in New York City. Obviously, we know pandemic has started in early 2020, with some cases even in 2019. The first death was reported in China on January 11th, 2020, and that really marks the start of a new era, a pandemic. Because that's really the time that it gave a global warning that serious disease has the potential to spread widely. So obviously, within a very short period of time, it spread to many countries, and now every country essentially. The first case that was recorded in New York. Obviously, before New York, we had some cases in New York, in US too. But the first case that was recorded in New York State was on March 1st, 2020, and within 2 weeks we recorded 2 deaths over there. It didn't take very much time for government there to realize that this is a very significant and serious disease. Between March 16th and March 28th, the city went completely on shutdown, starting with school closure, then moving to lockdown. Then on 28th, government actually shut down the whole thing, essentially saying that non-essential services have to be closed completely. And this pattern continued until sometime during summer, which is around mid-June, that they started to actually reopen again. for a number of reasons that we know that the number of cases has started to come down given seasonality factors and some other factors that are still limited contacts between individuals, reduce the number of infections in the population. But as we move towards the winter, fall and winter, then the number of cases has started to move up and the government has started to again respond to this surge of cases by closing the schools and reducing the number of businesses that they can operate or the capacity of businesses to not complete lockdown, but to a significant reduction of interaction between individuals. And this goes all the way to essentially December 14, that vaccination starts. Some of these non-pharmaceutical interventions actually continued way after a start of vaccination. But the start of vaccination actually marks really important date for New York City. They had enormous amount of infection and death during the first year of pandemic, and vaccination was a big deal for them in order to essentially reduce the number of death and infection by heavily investing in the program. So the question for us was really starting from December 14th all the way to end of January 2022, which is this year. What was the return on this significant investment in New York City? It's the largest investment in vaccination that has ever happened in New York City. So obviously after a start of vaccination, with the increase of immunity in the population, a lot of population burden or health burden of the disease started to decline. As vaccination coverage started to grow in New York City. So if you look at the pandemic trajectory in New York City, this is actually the actual data from New York City in terms of number of confirmed and probable cases. They had a number of different variants. Some of them are variants of concern and some of them are variants of interest. There are many of them, but those ones that are the key, you see here in terms of timelines of introduction into the population. And introduction into the population, what it meant for New York City is the first time that the case was identified with that type of variant. So we have Iota, which Iota is not really a widespread variant in many parts of the world, not even in US, but they had that variant. Then Alpha, early in fall, we start vaccination December 14. After the start of vaccination, they had introduction of Gamma and Delta within a few days apart. And then they go through the rest of 2021, which involves a small Delta wave, a small compared to, I guess, Omicron, and then introduction of Omicron, which comes with a really big wave. So the end of data on this slide is really the end of timelines for our analysis, but a start of analysis is really the start of vaccination. In terms of doing this analysis for return on investment, we needed a number of different types of data in order to feed into the model and look at the scenario of vaccination compared to a counterfactual scenario in which there was no vaccine. So obviously we needed to know how many vaccine doses were offered on every day, who got any of these doses, whether they were first, second, or booster, and what coverage we achieved over this period of time. Obviously, we also need the type of vaccine, which on this slide you see the Pfizer BioNTech vaccine. essentially starts from December, and the yellow part shows the primary series of vaccine, and the purple part shows the start of booster vaccination. So majority of primary was in the first half of the 2021, and then later on with the start of increase in Delta and Omicron, there was some additional investment to encourage people to go get vaccine. But clearly when we go towards Omicron, with understanding that waning immunity is part of this process, the booster coverage starts to move up. Very similarly for Moderna vaccine, again, very early is a huge number of primary series. Later on is mostly booster series. And if we go to Janssen vaccines, very similar pattern, except that a Janssen vaccine was approved very late, later than Pfizer and Moderna, around March. And not many vaccines of Janssen were actually, compared to Pfizer and Moderna, were distributed. If you look at the age distribution of vaccination, there is nothing surprising here. You can say that based on public health recommendation for most countries for vaccinations, that older individuals, you can see 75 plus individuals, they start their vaccination earlier than any other age groups, and it goes down towards younger age groups. And you can see 5 to 14 actually started quite a bit late into 2021, largely because the vaccine was not really approved for that age group. However, what is different in New York City compared to other population is that New York City did not have specifically 2 doses for primary series. Although this is defined if someone gets 2 doses as complete primary series, but they also had primary series with 3 doses. So for some of the individuals with recorded conditions, or if they were immunocompromised, or they had any kind of indication that they may be at risk of severe disease, primary series was essentially defined as 2 doses plus 1 additional dose that was added to the primary series, but it was the additional dose, which is the 3rd dose, was not considered as a booster. It was essentially part of the primary series for them. So later on, those individuals could actually get another dose as a booster. So when you see that some of these green curves, they're coming up relatively early for some age groups, especially older age groups, is because they had the 3rd dose of vaccine even before vaccines were offered as booster. Okay, obviously we needed to know the efficacy of vaccines for Moderna and Pfizer, which constitute the majority of vaccines in New York City. Those are about 95 or 96% of vaccines distributed there. We collected all the efficacy from the review of literature for different variants that we had in New York City. You can see Moderna and Pfizer, they're fairly close to each other in terms of their efficacy for infection, symptomatic infection, or severe disease. Moderna might have done slightly better, especially for those variants that have proven to have the capacity to escape immunity, especially for Omicron. Moderna was outperforming Pfizer vaccines. Okay, so in addition to number of vaccine doses, coverage, type of vaccine, vaccine efficacy, we also needed cost of vaccination programs. So the cost of vaccination programs, we split those ones into 3 separate sections. The ones that government actually invested towards vaccination campaigns. And you can see that on this slide, they gave us all the costs for different categories they had in their vaccination programs. And some of the largest one, obviously vaccine administration was the largest one with $1.87 billion. And advertisement and outreach was about 243 million. And where vaccine doses purchased was around $282 million. The rest of items are fairly small compared to these other items. This other category that you see, 30 million, that relates to implementation of programs for outreach, for example, documentation and information technology access, development of apps, and so on and so forth. So that's the first part that is largely incurred by government. The second part is related to the cost that would affect productivity, loss of productivity or the time of individuals. And these ones we also collected from the literature. And some of it also came from the data from Department of Health and Mental Hygiene in New York City. Like, for example, what percentage of population 18 to 65 that were vaccinated, they were actually working adults. And those individuals are going to have potentially loss of productivity if they encountered any adverse reaction to vaccine, either first dose or second dose, which could result in a stay at home and not attending to the work, and therefore there is a loss of productivity over there. So we'll look at Moderna, Pfizer, and Johnson, and in terms of percentage of individuals who reported adverse reactions. And in terms of loss of work days, it was estimated that after first dose, that was about 1.7 days of loss of productivity. And after second dose, that was about 1.4 days. So these are really the investment that population makes into vaccination campaign. The third part of it is really the cost of healthcare system. In terms of outpatient care or in terms of hospitalization, which is a split to non-ICU and ICU cases with the cost estimates that came from the department, number of emergency department visits, number of, for example, transportation, emergency medical services. So a lot of these factors that they had a specific cost were provided to us by the Department of Mental Health and Mental Hygiene, New York City. So all of these are going to a model, agent-based model, which we developed very early into the pandemic. And we, over time, we actually improved as our knowledge improved in terms of epidemiology of the disease, in terms of parameter estimates, transmissibility of different variants, and so on and so forth. So I'm not going to go through the details of the model, but the model is fairly comprehensive and has been peer-reviewed in a number of publications. But what I'm going to say here briefly is that the model has two components into it. The component that doesn't have vaccine and the other component that has vaccine. We had pre-symptomatic, asymptomatic, and symptomatic individuals. And if they were identified, they were isolated. Clearly, that was the case for symptomatic cases. With positive tests, they had minimum of 10 days isolation in New York City. And the model also accounted for reinfection based on waning of immunity in the population. So the outcomes that we had from the model, looking at fitting to vaccination situation in New York City based on the data provided, and comparing to a counterfactual scenario in which there was no vaccination. So the outcomes we got from the model in order to calculate our return on investment were distribution of loss of work days, and that includes those individuals who were symptomatic, whether hospitalized or not, they had to actually stay home 10 days. But if they were hospitalized, then the amount of hospitalization were actually added to the amount of symptomatic days that they were not hospitalized, or symptomatic days prior to hospitalization. Length of hospitalization in ICU, they came from the data that we had, and all of these were age stratified. We also look at the death, and this is the key part of it in terms of calculating the value of a statistical life. Okay, so now what I'm showing here is essentially two curves are on top of each other. The first one, which is green and yellow. So green is the actual 7-day moving average of the data provided. The yellow part is the fitting of the model to the data. So that's a fairly optimal fit to data. And the one that you see black with shaded gray area around it, that's the one that when we looked at the counterfactual scenario and we in the absence of vaccination. So you can see that around the time of introduction of Gamma or Delta, the divergence starts to happen. And you see that the no vaccine scenario stays above the vaccine scenario. And obviously it takes a bit of a time for immunity to generate enough population protection so that these two scenarios diverge from each other, especially with a slow start of vaccination in many parts of the world, especially in New York City. Okay, so what you see here, I'm going to let this run. This is actually the kind of representation of what the model does in terms of fitting to data optimization. So this is just a video, and you can watch this. So the blue one is really the average of all the realization that are happening, and that's about 1,000 independent realization. And the gray or the light blue area is all those independent realizations that gives the confidence intervals. And the purple dots are the actual data per 100,000 population death. So clearly you can see that before the start of vaccination, or shortly after the start of vaccination, we have a lot of death. And with vaccination, it starts to come down, the number of deaths. And eventually we get to Omicron, and you see that the Omicron is quite significant. Not as significant as infection compared to January 2021, because vaccine immunity was relatively strong in the population, but still it exceeded the number of deaths we had during the Alpha wave. Okay, so why the number of deaths is so important for us in the return of investment analysis? Because we're trying to calculate the potential years of life loss. And that means that we are essentially losing the productivity of individuals. We're losing years of life that individuals could contribute to the society. So clearly, when you look at, vaccine and no vaccine scenario, and you compare these two bar graphs together, you see that without vaccination, there is a significant loss of life compared to with vaccination. So in vaccination, it was estimated around 98,000 years of life loss. Without vaccination, we would have seen over 400,000 years of life loss. Majority of it is really on age groups 80 and plus. Okay, so how do we actually calculate the return on investment? So the part that I just mentioned related to that, it has quite a bit of effect on return on investment, and it relates to value of a statistical life. So the value of a statistical life, in a simple definition, is the willingness of individuals to pay for mortality risk reduction. This is a concept that has been debated for many years, and there's still a lot of debate around that what is the actual value. And there are a lot of different estimates in the literature, and even in different government agencies, they have different ways of calculating the value of a statistical life. So in the US, the value of a statistical life is estimated to range somewhere from $5 million to $17 million. So it means that an individual willingness is essentially changing in that range, with an average of 40 years of age for working adults. If you calculate that on per year, which is value of a statistical life year, then the value would change significantly in a very wide range. It can go from several $1,000s to almost $800,000 per year. So a conventional benchmark for US in terms of quality adjusted life year is around 100,000. And we use this 100,000, which is fairly conservative to a lot of other literature out there in terms of calculating value of a statistical life year. So if you look at that, then whoever dies at any age, the remaining life expectancy that is lost, that has to be calculated with a discounted rate, which in which case we use a 3% discounted annual rate to calculate how much of their life, how much value of their life is actually lost because of the premature death due to COVID-19. So that's how the amount of value of a statistical life lost was calculated. And calculation of those values actually depend on, a lot of it depends on the methodology, but the big factor in the calculation is really the per capita annual personal income, which is around $74,000 for residents of New York City. Now, in terms of return of investment, you need to look at the initial value of investment by the government or society and put all those together, whether they're direct or indirect. So some of it is indirect. For example, if someone loses 1.5 day of work because they have to go to vaccine, that becomes indirect. They have to go to get vaccine. That becomes indirect investment that they make towards vaccination. The final value of investment is really the difference between direct and indirect cost in healthcare with and without vaccination. So if you want to calculate the return on investment, you essentially look at the final value of investment, subtract from initial value of investment, how much you put into the system and how much you get out of the system, divided by initial value of investment that you put into the system. And if you look at, multiply by 100%, that you get the percentage of the investment that you get in terms of percentage, how much return you get from your initial investment. Okay, so putting all of these together, we calculated the direct healthcare cost and value of a statistical life. Without vaccination and with vaccination, you can see on these two graphs. For the direct healthcare cost in New York City, without vaccination, we expected to have $33 billion. With vaccination, it was about $7.5 billion. So you can see that it's already a big saving in terms of direct healthcare cost, and that includes hospitalization, ICU admission, emergency department visits, and so on and so forth, outpatient, for example. In terms of value of a statistical life, there were actually very similar amount of dollar value saved. Without vaccination, we estimated around $34 billion loss of life, essentially loss of value of life. And with vaccination, which correspond to the death reported in New York City, that was about $7.7 billion. Now, how much return we had, it depends on whether, I go back one slide here. The return depends on whether we consider value of a statistical life or not. But if you consider the value of a statistical life in your calculation of return on investment, then the return on investment shows that for every dollar spent towards vaccination, whether it was direct or indirect investment. So it means that whether government spend money directly towards campaign or whether individuals spend time getting vaccine and any other indirect cost, those are all investment towards vaccination. So for every dollar that the entire society spent towards vaccination, there was slightly over $10 return. So about $10 return for that investment, with say net saving of 51 or roughly $52 billion of saving. This is when you include the statistical value of a statistical life. If we exclude that, which is subject to a lot of debates and the amount of it, even excluding that, you still see that for every dollar spent towards vaccination, you still have roughly $4.3 return on your investment. And the net savings was roughly around $26 billion without value of a statistical life. So no matter how you calculate the return on investment, whether include the life, the value of life lost or not, vaccination had significant return in terms of averting the cost to the healthcare system and the society as a whole. So this is essentially my presentation. The concluding remarks, a few things that may be of interest is that the average years of life lost, we calculated, that was about 6.8 years per individual. And you can see that there is a significant value of a statistical life, the lost, even with vaccine. But if we didn't have vaccine, that would have been enormous, like over 400,000 years of life lost. That's a lot of value of life being lost without vaccination. So overall, the conclusion is that vaccination had substantial benefit, averted a lot of direct and indirect healthcare costs. And this study, because it's based on the data provided to us, provides really compelling evidence to continue with vaccination and booster as this pandemic and different variants continue to come up in order to prevent additional economic burden. A few things that I didn't say here, and it's good to be aware of them, or at least acknowledge them, is that the return on investment was solely on what happened in terms of healthcare cost and healthcare burden, essentially. So we didn't include, for example, how much vaccination contributed towards keeping businesses open and running at full capacity, because without vaccination, it could have been potentially the case that we had to shut down again, businesses go through lockdown, a series of non-pharmaceutical interventions we had very early during pandemic in order to avert infection and hospitalization or death. But those, in addition to causing health burden, they also cause economic burden because you're closing down businesses. But those were not actually part of the calculation here. So potentially our estimates in terms of return on investment is very conservative because a lot of other benefits to the society were not included into our calculation. So with that, I just want to acknowledge some of our collaborators, data providers, and funding agencies, especially the one that I'm involved in with Phil's Institute, Emerging Infectious Disease Modeling, Mathematics for Public Health. And if you are interested to see more details of this study, it just came out last week in JAMA Network Open, and you can freely access the paper. So with that, I'm going to stop here, and if there are any discussion or questions, I'm happy to answer.
If anyone has questions, feel free to use the little hand on the reactions.
Maybe I can ask a question, Seyed?
Yes.
Yeah. So you mentioned about economic burden. So,
sorry, I'm not sure how to get out of this. I'm not really good. Okay, so I'm going to have to actually. Sorry, Janhang, I interrupted you. I'm trying to get out of this mode so I can.
You indicated that it's the vaccine, the impact of the vaccine is underestimated if you don't evaluate the economic burden or its mitigative rate of economic burden. Or that could be in also different ways without vaccination. So so is the vaccination to enable people to go back to work, or that's because of this? So I'm just wondering what way you think will the indirect effect of the positive effect.
Right. Yeah, that's a gray area, I guess, that we didn't touch it, and we don't have really evidence or data to get a good sense of it. I mean, you could potentially say, yes, people are vaccinated, they're more likely to, to avoid infection and therefore go to work, right? Mm-hmm. And if we didn't have a vaccine based on the counterfactual scenario that we simulated, we would have seen quite a bit of, big waves of infection coming up. So vaccination might have helped in that context. People go back to work. And you see it right now. We have a lot of infections, but we're essentially back to kind of normal situation, and largely because of vaccine and booster. So the expectation is that if we didn't have vaccine, many of those interventions early during pandemic would have continued for much longer. And therefore, you either work at home or you don't work, or schools are, a school closure that might have been costly for parents. They may have to, rearrange the schedule. All of these come at the end of it. The summary is that there are some costs associated with it, right? And we don't have really good understanding of those costs, but the expectation is that vaccination would have reduced those costs significantly, which probably did. And that's why it's not included in our analysis in terms of any other aspects of the return on investment on vaccination.
Thank you.
Okay, the next question is Dr. Wolfson.
Hello, thank you very much for the presentation. I'm just trying to click on something. Anyway, one of the controversial things is the choice of, are you still there?
Yeah.
Sorry, discount rate. And 3% is rather high. The Canadian Agency for Drugs, Technology and Health issued a new set of guidelines for cost effectiveness evaluation a couple of years ago, and their recommendation was 1%. So that would probably change your results quite a bit. So I don't know if you did any sensitivity analysis. In terms of the potential years of life lost, what did, you know, I don't recall you saying how you calculated that. So for example, for an 80-year-old, did you look at life expectancy of 80-year-olds and take the difference?
Yes, so yeah. So go ahead, you complete your question and I'll go through the answer.
It's actually 3 questions, but because it seems to me the other big thing that you did mention was controversial was the value of a statistical life. And the value of a statistical life, the way a very cynical economist would calculate it for an 80-year-old might be negative because they have no earnings, but they're drawing Social Security and chewing up a fair amount of healthcare resources. There you go.
Yeah, so okay, so I'll go through one by one. So the first one, yes, true. In Canada is different, and in another analysis we did actually for economic evaluation of workplace screening program for Health Canada recently, just came out also last week in BMC Medicine. We use 1.5% as the discount rate. In US, 3% is actually recommended by, I forgot the agency, but the 3% is fairly standard in US. So the 3% discount rate mostly, well, essentially mainly affects the value of a statistical life, right? So if I exclude the value of a statistical life, the return of $4.3 would still remain the same because that doesn't affect the direct cost at the time that we are calculating that, right? So yes, it would affect some results when we look at the value of a statistical life, but without value of a statistical life, it would not affect the rest of the results. We did some sensitivity over that, which initially we actually used 1.5 when we submitted the paper, and the reviewers came back and said 1.5 doesn't apply to US, and they gave us actual references for that. So it's in the paper cited, and they wanted us to use 3%. So the second question was, sorry, I forgot.
You computed the life years lost.
Oh, yeah, life expectancy loss. It was actually calculated based on the life expectancy table. So anybody who died at some age, there is a remaining life expectancy, that difference was calculated as their age, remaining age. So that was the, and based on, there's a table and there's a reference in the paper for it, that for every age, there is a life expectancy. And for any age that they died that was recorded, then there is a remaining life that we calculated for years of life loss.
So a quick intervention, that's probably not the best life table to use because the people who were dying were probably suffering from multimorbidity, so they would have had shorter life expectancy.
Potentially, yes. Yes. The confounding factor is there, but I don't know if there was any other, actually we didn't look at it, but I don't know if there is any other table to say, you know, look at individuals who have any conditions and look at the average lifetime, because for different conditions, potentially a lot of different, life expectancy, right? So yes, that's a limitation, that we use the average of life expectancy for everybody. The third question, it was on value of a statistical life, right?
Yeah, for an 80-year-old, for example.
Right. Again, that's about, they're going to have very limited impact in general, but you're correct. And that was we did with without value of a statistical life to give a sense of, you had the return on investment. It was not like you lost anything or the return was insignificant. The return is still very significant, even without any value of a statistical life. You still have a saving of $26 billion in direct and indirect healthcare costs.
If I could be offered a quick comment, the Americans are going crazy with their values of statistical life. If you invested in every single intervention that passed that threshold, you would be spending GDP 5 times over.
Right.
Completely illogical.
Right. True. Well, we actually went through this discussion of value of a statistical life, and that's why we decided to actually add this without value of a statistical life to the paper, because there's a significant debate going on that, whether the value they estimate. And different departments in US, if you check their websites, like Department of Human and Health Services, they actually have very different value of a statistical life compared to Department of Transportation, because they have different data, and the way they calculate Department of Transportation, they actually look at the mortality rate of accidents, for example, that comes to their calculation. And in terms of Department of Health and Human Services, they're probably not looking at those data. As vastly different calculation they have. Yeah, and the range is wide. It goes from $5 million to $17 million. So that's a fairly wide range.
The old QALY thing in Canada was $50,000 per QALY.
Yeah.
Okay, we'll move on to the next questioner, Amy.
Hi, Seyed. I wanted to say also thanks for all your work during the pandemic. I mean, it was mentioned in the introduction, but there was, a lot of really nice papers outside of just this one that you did. And this is a pretty general question that's like beyond just this work. I'm just wondering, as someone who has done some kind of strong analysis on the economic impacts from both sides of intervention. So in this case, it comes out pretty cleanly that vaccination was worth it. I'm just wondering what you think of during the pandemic, how people have used the precautionary principle as an argument to justify usually the most conservative public health measures. So, the really strict lockdowns early in the pandemic, or, closing schools. So I think the precautionary principle says that the burden is on the government to show that, opening schools is safe. But I guess I feel like it gets used a lot of times, the precautionary principle, to justify the most conservative thing. And here you've done quite a nice analysis, putting dollar signs on both sides of the costs and the benefits, but you could also, phrase that in terms of lives as well. So I guess, yeah, do you feel like mathematical modeling of this type has a bigger role to play in terms of maybe being more formal about what is meant by the precautionary principle?
Yeah, I think so. We had actually some of the debates over our group over these things. I think some of the things that we say quantitatively versus qualitatively, the modeling part is good that you can quantify, but at the same time, I feel like a lot of estimates, especially early in the pandemic, were exaggerated. I mean, you look at some of the estimates very early, estimated like 2 million deaths in US over the course of a year. And, we had lockdown, and somebody could argue that if we didn't have lockdown, yes, we would have had 2 million deaths, right? But it's hard to quantify that because we don't have the reality of it, right? So we had lockdown. If we didn't have lockdown, we may have had similar amount of infection. In terms of economic impact is even more complex, because a lot of data that you need in terms of cost, they're not really clear. Like the cost of lockdown is probably very significant to population or government, but that cost, at least I haven't seen any paper coming out to say what the cost of lockdown was in the population. So it's hard to quantify a lot of these aspects based on any theory, right? But
Yeah.
modeling, if you know at least what you're doing based on the data, and you have very targeted question like the one that we had, which we still brushed a lot of stuff under the rug, like the one that John Hong asked. Even without vaccination, businesses may have gone the same way, right? We don't know. So I think modeling has a big role in quantifying things. That's for sure. But also depends on the availability of data and knowledge you have, right?
Yeah, and something I kind of realized, like listening to your talk, is, you know, people will talk about this many deaths were prevented by some kind of intervention, but deaths are never prevented. Like the person could have died from something else.
Exactly. So
like in some sense, all you're doing is delaying the mortality. Like it's probably inaccurate to be talking about preventing deaths at all. You should just be talking about years, like additional life years, like you framed it in your talk.
right. And there are limitations with that too, right? Because the way we calculate it, as you know, as Michael mentioned, we're looking at the average, but a lot of people who actually die because of COVID, significant portion of it is really those individuals who have some kind of chronic conditions, right? And those ones, they have significantly shorter lifespan compared to the average lifetime. So if they didn't have vaccine, they would have died probably earlier. They would have died because of the COVID, but it's not that they lost a significant amount of remaining life, because that's for the average population. But on the other hand, somebody could argue that, yes, when we look at the average life expectancy in the population, those individuals who are comorbid, that's part of the calculation, right? So it brings the average down slightly. Yeah, but you're right. A lot of these factors are hidden in the modeling side.
All right, the next question is Dr. Ern.
Thanks for a very nice talk, Seyed. I was just curious about the computational demands of what you were doing. So, for example, you mentioned that you did 1,000 realizations to get a confidence interval. What size of population did you use for New York City, and just how much computational effort was there in doing that? And that's actually, maybe that's set aside from also the process of calibration, which could be extremely expensive for an agent-based model.
Right. So for most models that we simulated or calibrated to any population, the population size is 100,000. So it's kind of per capita, right? In terms of computation power, depends on the complexity of the system. But we have a relatively large cluster at York, which has around 1,000 CPU and quite a bit of large amount of memory. So depending on how many scenarios and how many simulation and complexity of the model, it can go anywhere between few hours to probably somewhere between 2 to 4 weeks.
Okay.
So we had scenarios, especially very early in the pandemic, that the model was not optimized, that it took somewhere around an average of 3 weeks to run some of the scenarios.
Mm-hmm. Mm-hmm.
But in the past 2 years, we implemented a lot of optimization, particle filtering systems and things like that, that are still not to the degree that we want in terms of calibration. We are still not at the real-time calibration process.
Mm-hmm.
Yeah, that's not here. So if they give me the data today, or if I link it to the actual data that is being recorded on New York Times every night, I can't get anything out of it in real time.
Okay, thanks a
Yeah.
lot.
All right. I had one quick question for you. I'm not sure if this is too simplified a question, but if you remove the statistical life analysis and you look at just the straight up direct costs of the 33 billion versus 7 billion, they're
Right.
basically just measuring hospital costs. And then whenever anybody mentions hospital costs, I'm always wondering, is it because like you can actually link that cost to each patient? You know, like if you just link how much the cost is versus how much the doctors and nurses would be paid anyway by just being on staff. So I always wonder if that's, you know, an accurate measurement of hospital cost.
So, you know, I could say something and it could be wrong, but my sense is that when they talk about, you know, like in case of New York City, I believe it was around 113,000 per case of ICU. That's on average. Some cases are short ICU, some cases are relatively long ICU, and that affects the cost anyways. My sense is that those are all the costs of hospitalization and provision of care. I could be wrong, but I'm not sure if the salary of healthcare workers or doctors is counted towards provision of care. I don't know if anybody on the panel knows about this.
Yeah, no idea. I was just throwing it out there as a
honestly,
thought,
I'm not
right?
sure. I could be wrong if I say anything.
Yeah, that's somewhere where I'm sure we have to ask the people who are reporting the statistics to say, how did you create those statistics?
Right.
So anybody else with any other questions? If not, we're running almost to our finish time. Well, we'll say that's all for questions. Thank you very much for a great presentation and always an interesting subject area. And thanks for everybody for attending, and stay tuned till next week.
Thanks, everyone.